Hello everyone, welcome to today's webinar. So I'll share uh, something about Dr. Bilal Lab. So Dr. Bilal Lab was established in 1991 and it is a very renowned name throughout Rajasthan state. We have over 150 collection centers and around 1500 tests, and we have three center of excellence we have opened. First center of excellence is on oncopathology, second is on autoimmune disorders, and third is on lab medicine. So, why we have gathered here? So, CME is one of the most profound platforms which ensures that healthcare professionals maintain, develop, and enhance their knowledge and professional performance to provide the best possible care for patients. CME plays a critical role in the lifelong learning journey. With the same aim, we are gathered here today to explore and discuss one of the most pressing and innovative topics in diabetes. We are thrilled to have you here. Very good evening to everyone. Dr. Debaashish this side. I am a part of product marketing team at Dr. Lal Clinical Lab. So today we are gathered here to discuss about better understanding of insulin resistance and microalbuminuria in diabetes, and this will be taken care by Dr. Neelam Goyal. She is an MBBS and MD and a consultant pathologist at Dr. Bilal Clinical Lab. We will have a dedicated Q&A session at the end. Please feel free to ask your questions for optimal viewing. Ensure you are in a quiet environment. So without any further delay, I would request Dr. Neelam to take over and start the session.
Thank you, Dr. Devashish. So, we are here to discuss the topic of better understanding of insulin resistance and microalbuminuria in the diabetes patient. So, although it is a very well known and documented condition for years, but I think it's still a vague issues in many minds. So, why insulin resistance are discussed here? Because to point the role of insulin resistance in diabetes mellitus, hypertension, PCOS, it is very important to clarify that it is a measurable parameter and its measurement is easy, practical, and very useful in understanding the underlying pathogenesis of different conditions and consequently their management. So, what is insulin resistance? It is identified as the impaired biologic response of target tissues to insulin stimulation. All tissues with insulin receptors can become insulin resistant, but the tissue that primarily drive insulin resistance, the main are liver, skeletal muscle, and adipose tissue. So, insulin resistance impairs glucose disposal, which may lead to compensatory increase in the beta cell insulin production, and that may cause hyperinsulinemia. And whether hyperinsulinemia precedes insulin resistance, as it itself is a driver of insulin resistance. So, the metabolic consequences of insulin resistance, which include are hyperglycemia, hypertension, dyslipidemia, which may lead to endothelial dysfunction that progressively lead to cardiovascular disorders or diseases, metabolic syndromes, non-alcoholic fatty liver diseases, type 2 diabetes mellitus, PCOS, and obesity. So we can here discuss some epidemiology regarding insulin resistance. It is typically measured in the relation to the prevalence of metabolic syndrome. According to WHO 2016, the prevalence to be 41 million in children less than 5 years of age and more than 340 million in children and adolescents more than 5 years of age, which may ultimately leading to insulin resistance. And its also prevalence is increasing in the developing countries because we can also see the lifestyle changes and economic growth in our country. So it is increasing in our country also. So, assessment is very, very necessary for insulin resistance, and the gold standard test is hyperinsulinemic euglycemic clamp method, but that is not feasible outside research settings. So, for the assessment of IR, we are having HOMA IR test, that is homeostatic model assessment of insulin resistance. It is an essential tool in the clinical endocrinology for assessing insulin resistance, and especially for endocrinologist, diabetologist, gynecologist, gastroenterologist, and general physician to facilitate a better understanding of insulin resistance and improve patient outcomes. It includes a reliable, minimally invasive, and indirect method to assess IR in the clinical practice. So, why are we using HOMA IR? So, to monitoring the patients at risk of diabetes, we can see the diabetes in every family with the family history of type 2 diabetes, as it provides an early indication of insulin resistance which often precedes hyperglycemia. Assessment of metabolic status, which is commonly altered in the PCOS, and that is increasing in the health to screen patients who present with clinical signs of metabolic syndrome, which allowing for the timely intervention. To identify the patients with subclinical metabolic disturbances that may predispose them to future cardiovascular events. And it provides valuable information about a patient's metabolic health, particularly as it relates to liver diseases, chronic GI conditions, and metabolic syndrome. Key points which include early detection, non invasive and cost effective, and monitoring of the metabolic health in our body. And so, what is HOMA IR test? Basically, it is a calculation based test that estimates insulin resistance based on fasting insulin and glucose levels. It was developed by Matthews in the 1985. So, HOMA IR determines the IR, a calculator version, which is 2.2, which calculates using fasting insulin or C-peptide along with fasting plasma sugar levels. And the calculation included the formula is given in the screen share. So we are using fasting insulin and fasting glucose. So why only the fasting condition we are using in the HOMA IR index? So because after eating, insulin and the glucose levels, which fluctuate in the response of food intake, measuring fasting levels, which provides a clear picture of the body's baseline ability to manage glucose without the influence of any meals. This gives a more consistent and accurate assessment of body's insulin sensitivity. And also after fasting, the body's glucose and insulin levels are in a more stable state, making it easier to observe disturbances in the way insulin is working to regulate the glucose. If insulin resistance is present even under fasting condition, the body's insulin response will alter. That's why we are using fasting insulin and fasting glucose level for the calculation of HOMO IR index. So normal range is less than 1, which is considered the normal, and also this can vary by population and individual factors. 1 to 2.5, which suggests mild resistance, especially in the overweight or obese individuals. Elevated higher than 2.5, which indicates insulin resistant and the risk of metabolic disorders. So, what is HOMA model? HOMA model is used to yield an estimate of insulin sensitivity and beta cell function. So, but it cannot be used in those taking exogenous insulin. Under such circumstances, we are using C-peptide HOMA model, which use C-peptide to reflect endogenous insulin secretions could be used. Interpretation of the HOMA IR version 2.2 accept only the plasma insulin level under 2.9 to 57.6. C-peptide include 0.61 to 10.5 and blood sugar fasting levels are 54.1 to 450.5 milligram per deciliter. And if the values are outside of these ranges, HOMA IR calculation is it not possible. Clinical relevance of the HOMA IR is for we are screening for diabetes mellitus, pre-diabetic patients, polycystic ovary syndrome, which is very common in the today's life, cardiovascular disease, progression to liver fibrosis and cirrhosis, and monitor the effectiveness of lifestyle and medical interventions. What are the limitations of the HOMA IR? So it is accuracy in the specific population, variability, limited use in the patients with advanced diabetes, and it is not applicable to the patients on exogenous insulin. So, our today's topic, second topic is microalbuminuria. So, it tests what is the microalbuminuria. It measures the amount of protein called albumin, which is present in the urine, and it is a way to tell if your kidneys are functioning well or not. And it is also called albumin to creatinine ratio test or urine albumin test. So, kidneys are responsible for removing the waste products from the blood and regulating the water fluid levels in your body. Healthy kidneys make sure that waste is filtered out from your body, that nutrients and proteins that are essential to your health, such as albumin, stay in your body. If your kidneys have been damaged, they may not be able to keep albumin in your blood and it will start to spill into your urine. When this occurs, this is the condition we are known. It is known as albuminuria. And okay, and what is the purpose of the test of microalbuminuria? To measure the amount of albumin in the urine, and it is typically used in the conjunction with creatinine test to provide an albumin to creatinine ratio. How it is related to diabetes? Diabetes, which can cause damages to the kidney. In a diabetic patient, microalbuminuria confirms the result over a 3 to 6 month period, and it is confirmed of having kidney damage, and will be able to treat the kidney injury and help improve and maintain the kidney function. So it predicts an increased incidence of CVD patients also. According to the National Kidney Foundation, what is microalbuminuria is it is the presence of slightly high level of protein in the urine. Normally, urine albumin is less than 30 milligram per day. In the microalbuminuria, it is 30 to 300 milligram per day, and above 300, it is called as macroalbuminuria. This is the basic formula that how we can calculate the microalbumin in the urine. Diagnostic test urine albumin to creatinine ratio. It is a preferred method to detecting the microalbuminuria and it requires a random urine sample. We are collecting three types of sample, that is 24-hour urine collection, spot urine collection and timed urine collection. But the best method is spot urine collection. It is easier to perform than 24-hour collection and provides an albumin which reflects a single urine sample, and some interference factor are there which are higher than which causes higher than normal urinary microalbumin, that is hematuria, blood in the urine, fever, recently vigorous exercise, dehydration and UTI. What is the importance of detection of the microalbuminuria? Why it matters? Because it it helps prevent progression to the end stage kidney disease to a reversible mode and early interventions which can improve outcomes and delay dialysis or kidney transplantation. So, what is the takeaway or take home message? For microalbuminuria, there's a diagnostic significance because it reflects early stage diabetic nephropathy and can precede noticeable kidney dysfunction, or it can prevent or delay the progression of diabetic kidney disease, that is irreversible condition, and regular screening for microalbuminuria should be a part of diabetic care protocols. And for the HOMA index, it reflects the insulin sensitivity and helped assess the insulin resistance in patients with diabetes or at the risk of developing diabetes. Elevated HOMA IR index, it indicates a poor insulin sensitivity which is associated with increased risk of cardiovascular diseases and complication of diabetes. Routine testing, which also include in the diabetic care protocols. So, if you are having any questions or something, you can ask.
This is a request to everyone. If anybody has any kind of query, they can raise their hand. And please, if there is anyone, can ask anything, any query. Anybody? So in the meanwhile, I can ask one of the query, ma'am, like how will you identify the accuracy in specific population?
So, for HOMA index, right? For HOMA index, it is very limited for the specific population because studies have defined that the patient which are having liver or pancreatic dysfunction, there is very invariability in the different labs of HOMA IR index values. So it is a limitation for the HOMA index also.
Okay. Anybody, any query, you can raise their hand, please. So, ma'am, what are the variabilities and standardizations in this test?
Because there is a lack of insulin standardization in the across different labs, so it is variable. So we cannot standardize the procedure of HOMA index today nowadays. Later on it can be, but for now it is not.
So,
Because in the advanced diabetic which may cause a reduced beta cell function. So, and the only beta cell which stimulate the endogenous insulin secretion. So, if it is causing the reduced beta cell function, then it will not accurate the interpret the insulin levels in the body, endogenous insulin levels.
so I would like to request anyone if there is any query, they can raise their hand. So, thank you everyone for participating in this webinar. Thank you, Dr. Neelam, for sharing the story of IR and albuminuria in the diabetic patients. Thank you all.
Thank you.
Thank you.